Hello guys, how are you doing? So I'm going to discuss about something about the electrodiagnostic studies in the neurology. So these are the nerve conduction studies in the electromyography, and that's what I want to talk more about today is about that of the nerve conduction studies, specifically in correlation with that of the peripheral neuropathies, peripheral nerve diseases. So if these nerve conduction studies are most helpful in classifying a neuropathy pattern due to axonopathy degeneration, axonal degeneration, or it's a segmental or a demyelinated disorder. And that of the also the first thing is whether you can conclude or you can say that whether there is a peripheral nerve disease identified by this nerve conduction studies, whether there is a disease or not. Specifically, this nerve conduction studies usually studies that of the large myelinated fibers, which will usually give afferent innervation to that of the muscles, as well as they can to efferent innervation to the muscle, and the ones who take afferent sensory nervous to that of the afferent sensations from the for the proprioception and position and vibration sensation. So that nerves are the one who are studied by this nerve conduction studies. The nerve conduction study, as you said, it can study the large myelinated or the A alpha beta or gamma fibers. Those fibers are studied by that of the nerve conduction studies. So the small peripheral fibers are not going to be studied by this. There are other ways we can deal with small uh, fibers, small sensory or autonomic fibers. So there are autonomic tests to diagnose the presence of this small fiber tests, and there are also we can go for skin biopsy and the likes. There are laboratory or diagnostic workups for small fibers. So when you see nerve conduction study is nerve conduction study by stimulation of motor or sensory nerves and recording of the elicited action potential in the muscle. That's what we call is the compound muscle action potential, and the sensory nerve action potential is the main laboratory techniques in the nerve conduction study for the studying of this peripheral nerve function. As I said previously, what I want to talk you more about today is in correlation this nerve conduction studies function in the peripheral nervous system more of. So by transcutaneous stimulation of motor or sensory nerves and recording of the elicited action potential. In case of motor nerves, we will record the elicited action potential in the distal muscles, while in case of sensory nerve stimulation, we will see the action potentials in the distal sensory nerves. So by measuring this, we can assess one of the method of assessing the function of the peripheral nerves is by assessing that the action potentials, whether a motor action potential or a sensory nerve action potential. So the motor action potential are recorded in the distal muscles, while the sensory on the distal nerves. So the results of motor and sensory nerve conduction studies expressed as amplitudes, as you said previously, the amplitude, you can measure the amplitude. As the other important thing we can see from the peripheral, the nerve conduction study is the conduction velocity, and the other is what we call it distal latency. So that's in case of sensory nervous examination, that's what we call it. Um, the name is not distal latency, rather onset latency. We can call it onset latency. So in case of motor nerve innervation, we call it distal latency because there are two latencies, and the one near to that of the reference point is the one what we call it distal, while the one away from the reference point that we call it proximal latency. So if you say this compound muscle action potential, compound motor action potential, it reflects the summated electrical potential generated by the depolarization of a muscle innervated by the motor nerve, and the sensory nerve action potential directly represents the action potential in a group of sensory nerve axons, as I said previously. So this is what we call distal latency, Distal latency is the latency from the stimulus to the onset of the compound muscle action potential. That's what we call it, the motor distal latency. So this is, as we see here, the diagram shows the examination of the motor nerve examination, how we do. So there are two electrodes, electrode number 1, electrode number 2. So we will measure the action potential in the reference point. Here in the muscle, on the muscle in the term, the abductor pollicis brevis muscle. Here in the reference point, we can measure the action potential. So what is latency? Latency means when you stimulate the electrode here in this point, then before the onset of action potential in the screen here. So the time gap between the onset of the action potential the time gap between the onset of action potential and the stimulus. This is the A prime. This is A prime. That is what we call it, the distal latency between the stimulation and the generation of action potential. So this distal latency is important in assessing the function of the peripheral nerves. So in case of demyelinating neuropathies, the diseases or demyelinations which can affect the myelin sheaths of the nerves. So what will happen? So this distal latency is usually prolonged, while in case of axonopathy or the disorders in axons, this distal latency will not be affected unless there are significant or late stages. So this is one thing I want to say about this latency. So this is the action potential or the amplitude. Here we see is the amplitude. So in motor nerve study, we measure, as you said previously, we assess the amplitude at two electrodes. The benefit of this is to know to study the nerve conduction velocity. We measure the nerve conduction velocity by using by using the latency period from these two electrodes, and the difference between the latency period of these two electrodes. And we divide the distance between these two electrodes by the difference, between the latency period of these two electrodes. So what that means, I will tell you by showing the diagram. So the latency period, the electrode here, E2, the latency period for this electrode is here you see, as you see in the 2 prime, this is a B prime, is the latency, the onset latency, or the distal latency for the electrode 2. This is prolonged, as you see. Then the latency for electrode 1 is this one, A prime. So by subtracting the latency period A prime from B prime, we get C prime. So the difference in the latency, C prime. So we will divide, the distance between these two electrodes by C prime. Then we get the nerve conduction velocity. So this nerve conduction velocity is usually not affected in axonopathy or in peripheral nerves, which affects the axons, while in case of myelopathy, this will diminish significantly. So the other important thing is conduction block. So when you say conduction block, as you see here, the amplitude we measure in electrode 1 and electron 2 is the same. So this there is no difference in amplitude between two electrodes. So this means there is no conduction block or slowing between two sides. So if there is a conduction block or slowing, the amplitude is variable between two electrodes. So that's what we call is a conduction block. So the other important thing you want to see from this peripheral nerve study, nerve conduction study, is the late responses. These late responses are what we call the H reflex and the F waves. So information about this, what's the benefit of this H reflex and F waves or the late responses is that they tell us a conduction of impulses through the proximal segment of a nerve, including the spinal roots. So that's why we want late responses. So we discussed previously, this steady, that the early compound muscle action potential or the early sensory nerve action potential. And this distal latency usually tells us the impulse conduction distally to the distal of the nerve. So if you take the this electrode 2, it tells us the nerve conduction distal to the electrode 2, which means it will tell us the function of the distal nerves, peripheral nerve. When it comes to late responses, they will tell us proximal to the stimulus side or the electrode. They will tell us the function of the nerves proximal to the stimulus, including the spinal nerve root. So for the late response, for the late responses, for that means for H reflex and for F wave to be normally recorded, so their proximal nerves as well as the spinal nerve roots and the spinal cord ganglions should work normally. So besides this, what does it mean when we say H reflex and what does it mean when we say F wave? H reflex. So H reflex is worked by the same mechanism as that of these deep tender reflexes or stretch reflexes. When, for example, in case of deep tender reflex, when you stimulus, when stretches happen on the deep tendons, so the muscle spindles on the afferent sensory nerves in the muscle spindles will take this stretch, I mean sensation, the presence of stretch sensation to that of the spinal cord, and then the information will be processed and then will be an afferent muscle response for that stretch that's what we see. That is, then there will be a reflex response. So this H reflex works by the same mechanism. So for the H reflex to be to be recorded normally for both the proximal nerve segment as well as the dorsal sensory ganglion and the motor ganglion as well, the spinal nerve roots should be normal. In that case, we will see the reflex response on the muscle which will be recorded. On this H reflex is usually done on the tibial nerve specifically. So that's how we record the function of the proximal muscles. The other important study for the assessment of the nerves proximal to the electrode is the F wave. In case of F wave, so in case of F wave is the F wave response, in which case the response is elicited by stimulating a motor nerve, some of the action potentials that have traveled in antidromic fashion through the anterior horns. So when you stimulate a motor nerve, as we said previously, as we discussed previously in the previous image, when you stimulate the electrode here, as we can measure the impulse transmitted distally here, and some of the impulses travels back antidromically. So this impulses travels antidromically. After reaching this motor ganglion, they will turn back again, and we will measure these action potentials in the muscle, in the distal muscle. So that's what we call is late compound muscle action potential, and this is the F response. So that have traveled in antidromic fashion through the anterior horns are bolted back in again. Those who goes antidromically come back again in orthodromic fashion through the same motor neurons, and the late compound muscle action potential responses are recorded from the muscle innervated by those axons. So this is the F response. Then that action potential recorded is the one what we call it the late compound muscle action potential. I think it's now clear what does it mean F wave and reflex is. So when it comes to correlation of these pathologies with some of the peripheral nerve neuropathy, conduction block is demonstrated by a reduction in the amplitude of the compound muscle action potential elicited from the proximal side along the motor nerve compared to stimulation at the distal site. And the finding of conduction block is a main feature of a number of acquired immune demyelinating neuropathy. So we discussed previously what does conduction block means. When there is a variation between the two electrodes, the measurement of this amplitude between the two electrodes, that's what it shows us the presence of conduction block or sometimes conduction slowing. And the finding of this conduction block is the main feature of this acquired demyelinating neuropathy. That's GBS or CIDP are the commonest example. But the other important thing what I want to tell you guys is that what we call is temporal dispersion. So when you say temporal, this is the normal. This diagram shows the normal motor action potential. So when there is a stimulus, there is a distal latency between stimulus and the onset of compound muscle as the action potential. So this is the normal amplitude. Then in case of axonopathy, the latency is normal, axon disorder, but the amplitude is significantly reduced. The amplitude is significantly reduced. So while in case of conduction slowing, what will happen? The amplitude usually this conduction slowing is associated with myelin disorders or myelinopathies. So in case of conduction slowing, so the time to reach the impulse to reach the distal, the impulse to reach the distal muscles is usually, the duration is dispersed somehow variable and it's late. So in that case, the distal latency is somehow prolonged, and the amplitude is usually not affected since the number of muscles innervated is intact because the axons are intact. So the innervation, there is no problem with innervation. The amplitude is usually not decreased, but the waveform of the amplitude is widespread. Then that's what we call it. Because of the prolonged duration of stimulation with demyelination of motor axons, the same number of motor units activated, but over a prolonged period of time, and thus the compound muscle action potential has reduced amplitude because of there is a temporal dispersion of the waveform. As we said, the amplitude is not be affected by itself, not because of the denervation, rather than due to the decreased, the prolonged duration, the waveform of the amplitude is widening. So that will result in the temporal dispersion. That's what we call it. As you see the waveform, the amplitude is somehow widened. So that's what we call is temporal dispersion. And again, this is a feature of demyelinating neuropathies. So low amplitude, as we said, with relatively preserved distal latency, conduction velocity, and late potential along. We can leave that one. This feature suggests an axonal neuropathy, while slow conduction velocity, prolonged distal latencies, and late potentials, relatively preserved amplitudes, and absence of fibrillation. This is more of AMG. This AMG feature implied a primary demyelinating neuropathy. As you said previously, non-uniform slowing of conduction velocity, conduction block, or temporal dispersion. So these are the features, as you said. Conduction velocity is slowed. There's conduction block and temporal dispersion, which is the feature of demyelinating neuropathy. Specifically, this conduction, non-uniform slowing of conduction is a feature of acquired demyelinating neuropathy. That's opposed to the hereditary neuropathy, which shows a uniform decrement on conduction velocity. So this is what I want to talk today. Thank you, everyone. I hope we will meet another time on another video.